Welcome to SCR Connection. Thank you everyone for joining us. It is my pleasure to introduce our guest speakers, Dr. Randi, Leyva, and Dr. Ken Hopper.
Thank you.
Dr. Leyva is an assistant professor of medical education in the TCU and UNTHSC School of Medicine and is a visiting lecturer in the John Roach Honors College at TCU. Her research focuses on understanding how early childhood environmental stressors, such as unpredictability, drive behaviors that modern medicine often deems maladaptive or bad for health. Dr. Hopper is an associate professor at TCU and UNTHSC School of Medicine and joined the Physician Development Coach Program in July 2017. Dr. Hopper's life work has been as healthcare strategy, experience instructing and incentivizing clinical and social problem-solving approaches that result in health behavior change. In today's SCR Connection, Dr. Leyva and Dr. Hopper will give us an hour tour of human behavior. Thank you, Dr. Leyva and Dr. Hopper, for being our guest speakers this morning, and I will turn everything over to you.
Okay, again, thank you very much for having us join this discussion today. And today we're going to be talking on a very interesting topic. In fact, some might say, how in the world are you going to do this in 1 hour? But we're going to have a 1 hour tour of human behavior. And our byline is Ancient Creatures in a Modern World. So that's a theme we'll go into, not to steal our thunder, but that will tie things together and perhaps create a platform of commonality and understanding. So this lets us have, find solutions across the spectrum. Next slide. So today's agenda, just to hit the high level, we're going to be talking about two strange bedfellows, meaning they're somewhat paradoxical, which is logical thought and coexistent with unhelpful behaviors. One of the key foundational elements we're going to really bring forward, besides our commonality, is our social determinants of health. We'll talk about recasting, enhancing traditional mental health treatments in multiple venues. We'll go towards the end on having a run-through of where we stand with health policy and what the future thoughts are about that. How do we spin virtuously towards a different future? And the last one is an invitation to you as participants about what you might personally or otherwise change. Next slide. So let's start with a little bit of an illustration of the definitional confusion and functional confusion with the word behavior. I use the term occasionally, behavioral health literacy, not just health literacy, and I think we have even more of an issue in this area, of course, than even with health. So we have terms such as good, stable, or adaptive. Good behavior, we kind of have an personal idea of what that is, but it's kind of contextual. What one person's good behavior might be the other person's problematic behavior. Stable behavior, well, that should describe how even it is, how much fluctuation occurs, but we really kind of have that as one of the kind of an amalgamation of good behavior and not illegal or societally unacceptable behavior. And then finally, the more important term for our discussion today is adaptive behavior. We don't use that very often in common language circles, but it is going to be the basis of how we talk about resilience and growth or institutional chronicity. Next slide. And I think this goes to you, Randi.
All right, thanks, Hopper. So while we as humans often know what is good or bad for us per medical and public health guidelines, we often use that information to guide and dictate our own behavior in totally different ways than what we may know as cognitively as what we should be doing. So, for example, we all know that we shouldn't eat the whole bowl of leftover Halloween candy or 3/4 of a Thanksgiving pie in one setting, but sometimes we do it anyways. Why is that? Is it simply a lack of self-control, or is it a disregard for one's own health, or is there maybe something else at play? So I would argue that there are many factors at play, some cognitive, some behavioral, and some deeply embedded even into our DNA. So humans as a species have survived throughout time under grossly different circumstances than you and I find ourselves in today, with bowls of candy and fast food dollar menus on every other corner. humans evolved in very different social circumstances as well than we live in today, having hunting, having close, constant contact with family and friends, living in small hunter-gatherer groups, moving our bodies regularly to obtain food and water, etc. So with that also came a sort of shorter shadow of the future. So circumstances were less predictable than they are today in our modern lives, well, at least until COVID-19 hit. But with these pressures came changes to our psychology. And so we'll get into that a little bit later, the exact pressures later in the talk. But my point is to say that there are some good physiological and psychological reasons that we enjoy, for example, sugar and fat so much. When our brains were evolving into modern day humans, access to these items was fewer and far between than it is today. So we seek these items out not only for the energetic resources they provide, but also because our brains find pleasure and reward from consuming them. If this consumption happens only occasionally, it's really no big deal. But if it happens 3 meals a day and 2 snacks a day, well, we all know what happens. Weight gain, obesity, blood sugar and diabetes, tooth decay, joint and mobility issues, the list goes on. So while we know these behaviors are bad for us, we still often continue them. But we truly are ancient creatures living in a modern world. There's essentially a mismatch between how our brains evolved over hundreds of thousands of years and our current modern sedentary, high-fat, high-sugar, high-impulse, high-stress, socially distant, or fabricated world, which is what I like to sometimes think of social media as. So this is where I think the field of evolutionary psychology comes in handy to understanding personal health behaviors. It can be useful for medicine and public health interventions. And I think it's a really unique way to destigmatize certain behaviors and give a broader understanding of why people do the things that they do. So when many people hear the word evolution, they often think of sort of morphological changes to body parts in animals, not so much as in humans. But they think about things like the peacock's ornate tail or the giraffe's extra long neck. But one of the things that I like to always say in talks like this is one of my favorite quotes from one of my mentors. She used to always say, evolution doesn't stop at the neck. And I think that's a really great way to sort of break down the idea of the Cartesian split, that the mind and body are two separate things. We know from many advances in research across disciplines that is obviously not the case, and that what happens in the brain affects the body, and what happens in the body affects the brain. And so I think that evolutionary psychology is uniquely poised to offer insights about how particularly environments can impact behavior, particularly in my interests are in sort of these bad health behaviors. So, for example, eating things that are bad for you, or eating when you're not exactly hungry, that they can actually be very adaptive given the context, which I think is really useful for destigmatizing some of these behaviors that are often seen, as simply based in a lack of self-control. All right.
Thank you very much, Randi. I really do appreciate now kind of advancing the discussion to the next level, which is looking at, so what do we do? A discussion about our kind of adaptive nature, and we really are this set of beings that really does interact with our environment. We have to remember that. Well, this slide actually demonstrates that a bit. We have the 3 different frameworks for treatment intervention constructs that really memorialize parts of this. So if we try to do something about this and say we know what we need to do, that logical mind, versus what we are doing or have the tendency to do, then looking at the angle of the biopsychosocial model is a framework. It's the traditional psychiatric framework of looking at the multiple components, which is biology, kind of our DNA, and how our DNA impacts or is reflective of the environment. Diabetes type 2 in our country is a great example of this. Genetic tendencies with environmental stressors, not exercising and eating a bit like our ancestors would. the psychology, the family language, and life experiences, including those that are traumatic or helpful, and social, really referring to predominantly our current social circumstance. If we're obviously in a prison camp, we're going to have quite an influence of that traumatic experience on our psyche and our functioning go forward, even though we may be able to control it in some fashion. So the cognitive behavioral frame, two statements here that I think can help for those who don't know much about this is that mindset determines behaviors and that behaviors can cultivate mindset. It is a two-way street. And we'll talk about some examples in a moment. And the last one is one of the key elements we talked about, which is the psychosocial determinants of health. So this backdrop part of the equation is really a very strong driver of success and failure. There is an implied societal obligation to address this in some form or fashion because it involves us all, can impact us all. And if done early into outcomes, addressing social determinants is a true cost saver. And we'll go into greater detail in the subsequent discussion. Next slide. So we are really talking about a total person approach, okay? So this is not just mind or body, which is the way when I started my practice years ago, we really did practice, still have remnants of that, but it is looking at how these play off each other, which is the strong message of what we're talking about today. So good mental health and good physical health are travel partners. Okay, there is something called a virtuous spiral. And we've all been part of virtuous spirals, psychological safety, a variety of things that make us work well with the team. And then the opposite, the downward spiral, where it's like, oh my gosh, I don't know how to even let my talent come out in this environment. So we have experienced this in different settings, but in our body and in our psyche and our physical, we can use behavioral activation as an actual treatment to get started on having better physical health and chemical cascades that go in the positive direction. Taking a step towards getting something done for our health does start a whole process going in the positive ways. And norepinephrine and dopamine are often the neurochemical parts of that. Wellness over sickness and fewer medical visits ends up being the result. Downward spiral, untreated depression and chronic illness, you'll see in your resources in the literature that I have Steve Mellick's work, which is just on multiple occasions proven that these two together really lead to poor health outcomes, if not addressed. The inflammatory cascade is another consequence biochemically that is really talked about quite often about why certain illnesses keep just adding to their list. You know, diabetes, for example, high blood pressure leading to the next item, to the next item, to the next item. So there is inflammation that is involved with that and to some degree. So sickness over wellness is the rule and more hospital days and stays. Next slide. So this is, I wanted to make sure I had at least one very busy slide. So this, I want you to memorize this, and we're going to have you copy it down on a piece of paper at the end. No, not really. But I do want to show this graph. And this is from Dr. Roger Cathal's work, who is a foundational researcher, physician who is both an internist and a psychiatrist, who looked at this high end of this is couched in terms of spin, but it also means comorbidities. And what he and others kind of formulated over time is health complexity as a term, not just disease state, but health complexity. When we have the psychosocial determinants added into it, it's amazing, isn't it? If the 80-20 or 90-10 rule really applies here, you have this accentuating cost, and meaning they're in the hospital, ICUs, ERs, in inpatient units all the time. Folks who are on that high end of the curve. So this is important to start as early as we can in addressing this and address it thoroughly. So this gives you a little bit of perspective. Next slide.
So I want to touch back a little bit on what social psychology particularly can offer in the way of insights into different therapies and interventions that can be useful not only for patients, but I think also framing health professionals and providers their behavior and their insights in a way that I think is very, very helpful. So there's a wealth of research in social psychology that elucidates how we as humans have sort of limited cognitive resources, and because of that, our brains do a lot of shortcut taking in order to sort of keep us from becoming overwhelmed by our environments and all of the stimuli that we're taking in at any given moment. And so a lot of those cognitive shortcuts can often lead to things that we deem, especially today in a modern globalized world, as very antisocial or not good for society. So certain biases, particularly with out-group members, so people who are not of the same group as us, that could be different, based on different groupings. It could be race, it could be geographic region, family groups, etc. So that can lead preference for in-group members, and a dislike of out-group members can lead to tribalism and a variety of other sort of self-protective or self-promotive behaviors that can sometimes result in negative outcomes for out-group members particularly. And we see this in the way of politics. We see this in a variety of different fields where people are consciously or even unconsciously leveraging their own biases to their own advantage. And I think one of the really important things to remember is that healthcare professionals, while highly trained, are still human and still subject to many of the same biases and sort of mental shortcuts, especially under conditions of heightened stress. And disease threat, which we're all living through today in a COVID-19 world. But I think one of the interesting things is that people generally don't like change. But I think if this era has taught us anything, that we actually are very adaptive and that we can change rather quickly to adapt to changing circumstances. And so we see this happening throughout society, the way that society is sort of organized right now, ever-changing guidelines and sort of behavioral expectations. But we're also seeing change happening in healthcare as well.
So again, I think there's a trend here. I'm wanting to see if you're picking up on it, but I have the busy slides, all self-created. So, but this one is, again, I want you to just look at this globally. So really there is a reflection here. Society's evolving principles of how society, the individuals in our society would like to engage in health and health care. And then medicine's evolving principles. And we could discuss how, whether medicine's going kicking and screaming. I think there are some examples to show maybe we're listening in medicine, the big M, to what's happening. But also, there's always needs to be a little bit more energy to make change occur. We talked about the resistance to that in kind of a steady state fashion. So timely proximal care, or convenient care said in common terms, has been around for a while. Why do I have to wait in my doctor's office so long? Having really a connected communication or a real discussion, my doctor getting to know me, knows me as a person, seen as a person with empathy, is another element. Having efficiency, which means typically engineered pathways, but not over-engineered. Natural is a common word. Really appreciating what's happening in life and understanding that. Environmental influences is another shared kind of goal, understanding who I am and where I'm from, and really getting to some sort of outcome, both in short term and long term. So these really are kind of lining up as needs and wants and things that are happening within healthcare and medicine. Next slide.
So touching back on sort of the value of thinking about human behavior from an evolutionary perspective, I think this whole idea of sort of leaning into natural processes and thinking about the conditions under which our brains and bodies have evolved and how we are sort of living in a mismatch in a society that is, like I said before, highly sedentary, highly chronically stressed. We don't have sort of that ability to turn off stress in the way that our bodies would prefer we do. So an acute stressor would be, maybe an immediate threat, something that's dangerous. Once the threat is gone, our body is able to relax and turn that sort of stress response system, the HPA axis, which Dr. Hopper will talk about here in a few minutes, But when we have that chronic, enduring stress, particularly, with our very busy, overwhelming work lives, managing that with family and other competing demands, that chronic stress can lead to a lot of very detrimental health outcomes. So sort of getting back to basics, these items I have here listed on the slide, and again, we all know these things. This is nothing new. We know we need to sleep, exercise, eat healthy, and watch our stress levels. But putting that into practice is not always as easy as just, listing it here as a succinct list of things that, we all know we should be doing. So while we don't always have complete environmental control, so think COVID, we do often have control over what we put in our bodies, how we manage our sleep and sleep hygiene, so think no screens in bed or before bedtime, what we consume, how we approach moving our bodies and cleansing our minds. So really just having a mindful approach to stress and stress management, I think, can be a very valuable tool for increased overall physical and mental health.
Great. So this is really the beginning of a dive into some of the context, and Randi and I, Dr. Leyva and I, are going to be looking at these kind of sequentially together. So I start with this slide, and to give backdrop to this, it is interesting if you think about it cognitively. We've been talking about that and these biases and automatic thoughts that coexist. They were kind of programmed to have coexist. One of the most outstanding is when you really stand back from it is, wow, it's interesting that is there a principle that actually there is an important psychological or kind of adaptive kind of principle to say when there is some environment that is not helpful, we don't do it. We don't go there. And there's a whole growing body of literature, and I love to tell this to patients, is the common sense thing to do is the common sense thing to do. It's not weakness. It's not, it has nothing to do. It has to do with the way we are programmed. Okay. So we were part of our adaptation was to have certain things we automatically do, even now in modern society that might be detrimental to us. So again, that's part of the message. Had a purpose perhaps in a different environment, but not now. So pick the most outstandingly common situation. And when you work with people who have some level of drinking problem, one of the first things as they've had a night of going out with the buddies is that they will place almost everything in terms of guilt and how they failed, okay, and which is not productive. And if you think about the core underpinnings of AA, if you know much about that, it is around not being in the environment, having a different environment, having mechanisms by which we don't let ourselves drift into those environments. So this is really context. It's kind of it's a specific context, but context and environment matters. And it actually is a psychological, psychiatric, foundational element of how do you get better. Next slide. So, yeah, go ahead. I'm sorry. That's what we're going to share this towards the end.
Yes. So thinking about sort of ongoing environmental stressors and how cues in an environment, like Dr. Hopper was just mentioning, if you want to avoid drinking, avoid settings where drinking is common, or avoid, bringing alcohol into your home because there's a higher likelihood of engaging in the behavior if you have access to the substance. And so thinking about that coupled with the idea of ongoing sort of environmental stressors, there's a whole body of research looking at the psychology of disease threat. And again, touching back on the fact that we are all living through a global pandemic, I'm sure this is top of the mind for many of you. Maybe you don't think about it in terms of disease threat. And I mean, you probably feel threatened by the disease, but you might not think of it in quite this way, that it may be impacting your psychology and that of others around you. And so what the research shows is that disease threat or pathogen prevalence in an environment, not only with humans, but a lot of other animal species as well, that it can increase stress, it can increase tribal responses. So like I was mentioning earlier, sort of that preference for in-group members, a dislike for out-group members. So xenophobia, the likelihood of overt racist acts, language, and behavior, for example. a distrust or dislike of out-group members. There's even laboratory-based research showing that when people are put under conditions of disease threat, even artificially created in a lab, that they tend to have a preference to punish out-group members and desire out-group members to have less reward for equal work and equal activity. And so it also increases the likelihood of conformity to in-group norms, which I think is a very interesting aspect of how this environmental stressor can impact and change the way that we behave every day as individuals and as groups, that can be maybe very self-protective, but also very detrimental to others, considering that we now live in a globalized, very diverse society. Dr. Harper?
Yes. And so, it's interesting. I'm picking up a little bit about the chemistry. There is I couldn't be a psychiatrist. I'd probably lose my credential if I didn't mention the hypothalamus pituitary adrenal axis. So HPA, you can just know it by HPA. But this really shows that as we take in information through our eyes or other sensory modalities, the hypothalamus is right in the middle of the process of processing through that, and then having our hormones get into overgear. So we basically, as you can see, adrenal axis, meaning adrenaline or norepinephrine, we get this fight or flight syndrome. So we have this chronic level of this going on and getting into a disequilibrium as we move from acute to more chronic stress. For providers, there are many that have had this for a while, but now on steroids, which is burnout, getting to almost be depersonalized and not really engaging in quite the same way. So it starts to create this downward spiral, just as we talked about before. And we can have several of those that start getting into place. So there are things to be done. We're not here to talk comprehensively about that, but there are ways to do this, and agencies and organizations are doing it. And it has to do about creating purpose and being able to share and deal with the emotions kind of within the team. The pandemic downsides, obviously, is that, we have people not being able to get care because things are tied up with COVID. So maintenance and preventative and proactive care, we don't want to let that go, but it's happening in a lot of locales. Relative upsides, well, and I say relative with capital because, and one of my favorite sayings, maybe it's just because I'm always creating lemons, but it's making lemonade out of lemons, and that is technology has really advanced. Telemedicine, telepsychiatry, telemental health has really advanced. The other one is if we can learn as a culture, things are going to happen. World War II is going to happen because of Pearl Harbor being bombed, okay? Those things do happen in mankind, but how do we use that as a lesson of not letting it happen or mitigating from it happening again? So hopefully that will be coming as a result. Next slide.
So you mentioned social determinants of health earlier on in the talk, and this is an area that's sort of hot in the literature right now, especially in the public health literature. And for me as a social psychologist, it's sort of the bread and butter of what my research focuses on, which is looking at early childhood environments and how they serve as a blueprint for the rest of the life course. And so using life history theory, which is a subset of evolutionary theory, to look at how sort of the behavioral patterns that begin in childhood as a means of thriving and surviving persist throughout the life course. And so my research specifically focuses on eating behavior, which is related to what I sort of opened the talk with discussing. And so what my research finds is that for people who grow up in environments that are predictable, that they're resource plentiful and rather benign, that they tend to eat when they're hungry and they don't eat when they're not, which is nothing special or to write home about. It's pretty intuitive and something that you would expect. However, what I find with individuals who grow up in more unpredictable circumstances, and this is not specifically around food accessibility, this is just general unpredictability in a household or neighborhood or community environment, that people who grow up in these unpredictable and typically low resource environments, that they tend to eat comparably regardless of physiological energy need. And so rather than waiting for a physiological cue, such as a feeling of hunger or lowered blood sugar, they'll tend to eat comparable amounts of calories regardless. And I see this as a highly adaptive strategy that likely enabled our ancestors to survive times of famine. So thinking about an example, if there was a child today in modern times who has a very unpredictable home life, doesn't know who's going to be there when he gets home from school, it might make very adaptive sense to eat when food is readily available now rather than waiting until later. And so we are able to consume extra calories and store that in the way of adipose or body fat, which I think is a way that we evolved as humans to enable us to survive during unpredictable times or times of famine. So in addition, there are a variety of other areas of research with human behavior that I think evolutionary psychology has really useful insights. So for example, these unpredictable environments, especially environments that have a lot of danger, tend to increase a person's likelihood of attentional switching. So that's the ability to switch attention from one topic to the next very quickly, which can be very useful for avoiding threats. And it's also a symptom of attention deficit disorder. And so thinking about how these behaviors could actually be very helpful. We often think of ADD as being this very detrimental thing because of that, because of our environment and what we the demands that we put on attention and prolonged attentional focus in classroom settings and professional settings, et cetera. But there may actually be some very adaptive benefit to being able to switch attention quickly and often. Another aspect of behavior where I think these social determinants of health and how early childhood environments serve as a blueprint is having a shorter shadow of the future. So if an environment is relatively resource depleted or harsh, people tend to have a shorter shadow of the future, meaning they don't see the future. They don't perceive the future in the same way that others do. So, for example, if you ask them how far away does 3 months feel, a year feel, 5 years, they're not quite able to they don't perceive it in the same ways. And so what this leads to often is less saving of money, more impulsivity, and also that attentional switching that I was mentioning earlier. And so I think that, there's a lot of use in thinking about these early childhood environments and how they can set a blueprint and leave a residue on us throughout our life course, regardless if those circumstances change. And I think that's one of the really unique and interesting ways to things about evolutionary psychology in my research specifically is that even if people come out of these circumstances, so they are able to get to a better place socioeconomically, the behaviors still often persist, regardless of a change in that environmental stress. So thinking about childhood and childhood trauma, the Adverse Childhood Experiences Inventory is a very useful clinical tool that psychologists and medical professionals will use in settings to determine the amount of childhood trauma or adverse childhood experiences that an individual has experienced in their lifetime. And it has a variety of different questions about parents being in and out of prison, physical abuse, substance abuse in the home, sexual abuse, a variety of different factors. And again, it's a very quick way to assess a person's risk for childhood trauma and then also some later detrimental effects later in life. And so what the research on the whole shows about the ACE is that people who have higher ACE scores, that they tend to have lower mental health and lower health, general physical health over the life course, meaning that they tend to suffer from more depression and anxiety. They tend to suffer from more physical ailments and comorbidities. And so, zip code can be a strong predictor of future healthcare costs, but also, I think something valuable to think about here is that childhood environment and how that correlates with zip codes, particularly for people who are in highly stressful or low socioeconomic conditions.
Okay, so this is a kind of a summation slide, and you've heard these concepts actually before. To bookend what Dr. Leyva was talking about in the consequences of trauma is that it is got the downstream or through life effects correlate with incarceration rates, with things even outside of healthcare. So it is a societal issue. We are in Fort Worth, Texas, in Tarrant County, and it's a community that's interesting. It's a city, but it's also known to be fairly tightly wound. We're certainly a small enough kind of community as a city to be able to have some community initiatives. We have the Blue Zone Healthy Kind of Habits initiative. There was a initiative brought forth with the medical schools and with the Morris Foundation to look at what can the community do. So there is a dramatic need to look at these things and try to be unique in how we address them. So on this front, just to remind us, health complexity is what it is. It creates a vicious downward cycle between mental health decline and medical decline. Chronicity becomes entrenched. Early intervention, just like taking your antibiotics at the sufficient dose at the right kind of pulsing in those 10 days to 2 weeks, is critical to get the infection under control. That's true for those two. Really having early intervention and having it appropriately, dosed is critical. So we either pay now or we pay later in multiples. That's just the fact. We can't change that. It may be that we could blame different things on it, but we can't change that. There is a price to pay for not addressing it. So the last one is kind of just to give you a little story about this, because my past was having these kind of initiatives with major health plans that I would set up around the country, and I did quite a few of these kind of interventions and using value-based case management. But if I went to a blue state, I better use the word resourcing. Don't use that really evil word financing. And if I went to a red state, I better not use that really evil word resourcing. I better use the word financing. So it is interesting, tomato or tomato, it is the same thing. We have to address it, and it does cost resources, money to address. Next slide. So what are we doing about this? I'm going to talk about primary care. It's important to know there's a lot of work happening in the primary care venue. And it really addresses some of those prized elements that we share between our medical profession, provider professions, and with the population. Efficiency, convenient results, and results that persist are all kind of targets within the primary care integration efforts. So here are some on the left margin, some examples, and I'm just going to hit the highlights. Lessons of Project ECHO. Well, ECHO, we kind of have a visual in our mind, and I think it's well named. This started at the University of New Mexico and for New Mexican doctors because there were not enough gastroenterologists when we had that increasing wave of hepatitis C that was difficult to treat. So the expertise, they just didn't have enough referral specialists to go around to treat the population. So they came up with this idea, which is based on a key principle in medical training, and it really fits cognitive, learning too, which is see one, do one, then teach one. Okay, so demonstrate what you've learned on your next case. So that is what happens here. So there is a case conference kind of format. And they're doing this for depression, substance use now, too, where you really do get kind of an expert opinion about what to do in a presentation, this discussion. Then you eventually come up and can refer cases. You're doing the teaching of what you did, always with iterative learning and input coming into it. So it's an effective way to have this kind of spreading of behavioral treatment literacy happening within medical context. The Cherokee, it's a very famous model of integrated care, where they use really a behavioral psychology kind of approach to saying everybody's got these human behavioral characteristics. Let's address and have a plan around that and have that resource very proximal to any patient that's in the clinic and at any time the patient comes in. it also looks at how do you dose psychiatric care within that context. Collaborative care is similar in some of those elements, except it adds also an element of what's called registry. So a very systematic view of looking at depression scores, anxiety scores, at chemical dependency use scores, and really prescribes that people need to stare at that roster of scores to really say, okay, as a psychiatrist, I may suggest we do this with this. So it brings the team together on a common sheet of music, looking at outcomes and doing that in a very timed fashion. Over 90 studies showing, that's very productive and even economically, financially productive. Team care marries value-based case management, and there's an article in your literature that talks about that. I collaborated on that, and it was released this fall, has Take All and some other doctors in it, but looking at the grid of how do you go about measuring how this case management, helping people on the street, et cetera. So it's a very, very effective kind of combining of two different efforts together, and does have a very productive outcome. Next, please. So this is really around the use of technology. So just thinking about this, I wanted to pick a picture that showed us, we didn't use technology this way in the past. Now that's from a long time ago, maybe before I was born even. So, but obviously, I remember as a kid though, being a product of being a child in the 60s, I remember we used to say we may even be able to talk over the television. So the words TV was the common language. I don't think we use that hardly at all anymore to describe these tubes that we're looking into. But this has evolved, obviously, very much in this COVID period. So the question is no longer why do we want to do this, but why not? Why don't we want to do it? Because people have needed to use this technology, at least as a portion of the visits that occur. Telemedicine, telepsychiatry, lots of advances on convenience, workflows for providers, telemental health, delivering this behavioral activation and other psychological functions and oversight within that venue. And then we're going to pick it up, Randi's going to pick it up and talking a little bit about asynchronous learning.
Yeah, so asynchronous learning is being used in a variety of different ways in mental and medical care. In ways that is very helpful to patients in order to sort of keep them on their health journey, even while they're not in the doctor's office. The education continues, and so it's sort of a way to move beyond this sort of simple bedside patient education model. And so some of the ways that gaming and other technology apps are being used that's very helpful for patient education and increased health is through apps that help adolescents prevent relapse with substance use disorders and recidivism for those who've been involved in the criminal justice system. There's also apps used by PTSD survivors that experience nightmares. And it is sort of this interesting app that you can use that will jolt a person awake if they're having night terrors. Also, in our recently founded medical school at TCU in the UNT Health Science Center, there's a narrative medicine program that sort of teaches physicians the value of using stories and of how to listen to narratives and how to pull out the useful information from patient stories, and how using stories with patients can be very helpful for patient education. And then last is community-based interventions. And so I think historically, the model was often to go into communities and tell communities, here's what we're going to do to help make this a better place. And I think that there's been a really great push for, instead of doing that, instead going into the community, doing focus groups and asking the community themselves, hey, what do you need? What can we do to make this better, to improve your health or improve your circumstances? And so these are just some innovative ways, I think, to asynchronously include either technology or alternative strategies for increasing health literacy and health behaviors.
So again, keeping my trend with having a busy slide, but a very important slide, this is, as we round it out and wrap it up here, I would say this, and what Dr. Leyva was talking about, that it is very important that we look at all the modalities. I think it is high time that we think about all of us as stakeholders in community, national, state health, okay? Because health is not, I think we have gone quite an interesting direction in health plan accountability and bandwidth of what the solutions may be, and part of the reason why there are failures in that. So this does need to be a stand back and look, and how do we get this culture of embracing health and dealing with our ancient mind in this modern world. There are some side notes going into this around artificial intelligence. Some people think, wow, this computer's going to tell us what to do. Just to mention of that so you kind of can frame it in your mind, I think of it as an extrapolation of what we did in one of my health plan experiences, where we had archetypal messaging. Okay, so we kind of understood different folks had some characteristics where a type of messaging would resonate, so they would be motivated more. So data and observation can help us target what is the most effective, so we don't have a lot of wasted begging and cajoling happening around health, but rather what would speak to that person. Motivational interviewing is a tactic that is like that, but it can be pretty scientific. So if you wonder where AI fits in all this, it could have a place, but maybe different than what you might be envisioning. The backdrop of health policy, and this is where Joe Parks is really channeling through me. Joe Parks is the National Medical Director for the National Council for Behavioral Health. I've been on his Medical Directors Institute since its inception a few years back, but really a very staunch kind of advocate for behavioral health and integration, and then freestanding services. So I asked him to give his input, and this is peppered into this. So health complexity, the backdrop is health complexity. We've talked about that. A fragmented, expensive, and administratively burdensome healthcare delivery. I think we all have probably either experienced or know that. First generation integrated care fee for service. There have been some recent advancements in the last several years around collaborative care, that model we talked about, and coordination of care reimbursement. So we don't have to go unfunded in a fee-for-service world about how we get paid for those. Not much money, but it is certainly something that can cover some costs. Policy, innovation, and financing targets. Okay, first of all, integrated care across all specialty areas in medicine and healthcare settings. This mindset, this approach of looking at health behaviors and understanding there's a spectrum of severity and being very urgent to get in front of it, all are important. And to have that in all healthcare settings is just woven in like getting your blood pressure taken, is really we need to be able to promote that culturally and financially. Funding method for non-traditional healthcare services. I was talking with Dr. Leyva, and we were talking about health plans, insurers. One of the things some people don't know about them is that they sometimes set up a fund that is kind of an entire fund because they can't, under the health expenditures, be able to pay for housing and food. It's really not allowed. That's not a health benefit per se, but they will set up a not-for-profit organization that can. Okay, so that little known fact that many of them do that, and I'm not saying it's all a wonderful high level, because we do know it does decrease costs, but it does in such a way that the person is also getting better. So having a funding method for non-traditional healthcare services like that would be helpful across the board. PAR financing for addiction care in all settings. This is a place that if mental health is not understood and not funded well, that is in space with substance use treatments. So it is the stepchild of the stepchild, I guess, was one way one could look at it. So changing also the funder-provider relationship. So I'm on a panel at the National Council looking at how to overhaul medical necessity. If you've ever had a denied claim, it feels like, and oftentimes is, just saying, is there a reason we can possibly not pay for this kind of perspective? And that is not yet the health system or anybody in a good place. So there's work on how the accountabilities of both provider and funder match up using tools. One of them is the Cal Locus tool, but taking it to another level of partnership. So there is work going on in this relationship that is kind of behind the scenes, but it really needs to be where we can have innovation funded. Also, creating partnerships with communities, as Dr. Leyva talked about and I have alluded to within Tarrant County, and then a proactive care financing approach. Preventative care has usually been, something that we don't fund. We call it preventative, but proactive means more proximal, not way off, but that has not been well funded. So having this change of I need to prevent things, but in a proximal way, really requires some overhaul in how our financing is done. So these are the targets. And I'll say to Joe, I hope I did a good job for representing what you would say here. But I know, being on his committees, that this is something that we work on. The APA, AMA are working on actively. So this rounds out our main discussion about a tour of mental health. Some things are left out, but other things were included because we thought they were not covered at all. We left out medication advances. That will be in a different talk if we're able to do that. So, Dr. Leyva.
So, in closing, I want to just challenge you all to think about, now that you've learned a bit about evolutionary psychology and some of those sort of evolved mechanisms for the way that our brains work and how they influence our cognitions and behaviors. So whether you are thinking about it personally or professionally, think about what biases or perceptions or blind spots or maybe environmental stressors that you are experiencing or your patients are experiencing, and how that is impacting health behavior and health outcomes.
Yep. And then we have a second question to balance it out and to look at two different dimensions. So the next challenging kind of question is, what will you do to improve your or society's health? What steps can you take using behavioral activation as a challenge here? And so think about that. This is not to necessarily share, obviously, but is a charge and a provocative set of questions. So we appreciate your time today in discussing this. We get rather excited because we love this advancement and the work that is going on. Wonderful comments over in the chat about the ACE study and some other things. But we wanted to leave it for a couple of questions. It's almost time for this to end, but I think that there could be some questions we're able to take from the field if you have it.
For that wonderful presentation, we have time for a couple of questions.
Okay.
So if you would just want to enter your question into the chat, and they will be able to answer that for us.
Oh, what a wonderful question. And being the person who's worked in the health plan world, it is very interesting because there are several elements of this. Is poverty considered a pre-existing condition? If no, why not? Okay. So it is interesting because there are several ways to go about looking at this. Certainly, poverty is a pre-existing kind of influence that obviously does everything around kind of knowing what will happen around the continued expenditures, incarceration. But I read into that a little bit that could insurance use that as a way to exclude? Because we've been talking, that's been in the media recently. Can pre-existing conditions be used as a method to exclude somebody from health benefits? And if that were the case, it is definitely, and I saw the health plan world evolve through multiple generations of this, but it would be that we would cut up our nose to spite our face if we did that, because we would, our ERs, kind of the safety net facilities, would basically just be overrun if we didn't kind of say we were going to do anything about it. So it's more like, how do we run into that? How do we try to prevent, and or how do we use some techniques that are mitigating to the effects of trauma? Dr. Leyva, do you have any comments you'd like to add?
No, I didn't have any comments on that one.
Okay.
There's another question. How quickly should you deal with depression if it becomes a pattern? I think that one might be for you as well. Yeah, okay, very good. And we'll talk about it, and we can both kind of pepper this in these few minutes. But there is depression. If you're thinking you're depressed, there is a tool called the PHQ-9
if you're to write that down, PHQ-9, that is a kind of an inventory simply of the symptoms that are diagnostic of depression. You know, think coming and going, if you're finding it more often, it's worth at least counseling. It's worth at least a therapeutic approach of saying, how do I kind of prevent this cycle of kind of shutting down or having, you know, not being as engaged. So it's kind of this what tool. So I think you want to address it, anybody who's having this, but the modality by which you address it might be different depending upon the severity, how often. But it is important to get in front of it. Therapy and medication, even if you have a higher score, really it's not advisable to do one without the other if it's more severe. And so combining them will lead to kind of preventative effects and empowerment if you have with therapy rather than medication. And vice versa, sometimes you can really work in therapy quite a bit, and if you don't have a bit of help to get out of the ditch, then the therapy really won't be as effective. So I would say really assess yourself and be sure if you particularly have any self-destructive thoughts, suicidal thoughts or whatever, which can happen when we get worse. Be sure you contact your doctor right away. And there are we didn't put it here, suicide prevention lines that are there. That can be a consequence of also the isolation that we're experiencing right now.
Thanks, Dr. Hopper.
That's all the time we have for questions. If y'all would like to answer the questions in the chat, I just have a couple more items to cover before we end today's presentation.
Sure.
Okay. Oh, so do we want